Welcome everybody. I am Shader Reyes from Heart Trending. With me is Dr. Aaysha Cader. She is a cardiologist at Ibrahim Cardiac Hospital and Research Institute in Dhaka, Bangladesh. She is one of the early career blogger for the American Heart Association. Welcome Aisha to the show.
Thank you so much for having me, Shadi.
Aisha, you did a phenomenal job covering the AHA as a blogger as well as on social media. So there was a lot of science coming from the scientific sessions. What is your take in general on the AHA?
I think scientific sessions was really phenomenal, despite the fact that it was virtual. There was a lot of live featured sessions and a wealth of on-demand programming as well, which I'm still catching up on. And in terms of late breakers, I think in spite of COVID, we saw a lot of really great trials being presented across all subspecialties, be it intervention or prevention, and especially heart failure. I mean,
Correct.
what a phenomenal year for heart failure.
That's great. So without further ado, I would like you to take a deeper dive and at a couple of trials.
Just like to perhaps discuss a couple of trials presented by Dr. Deepak Bhatt on the fourth day of AHA scientific sessions on sotagliflozin, which is a novel SGLT1 as well as SGLT2 inhibitor. So we know about SGLT2 inhibitors, but SGLT1 inhibition leads to additional glucose elimination via the digestive tract. And more importantly, this action is not dependent on kidney function. So the first of the trials presented was Soloist WHF, and in this trial, they looked at type 2 diabetic patients with recent admission for acute decompensated heart failure who were treated with IV diuretics, transitioned to oral diuretics, and stabilized off oxygen. And they were randomized 1:1 to sotagliflozin or placebo. This was done either before discharge or within 3 days after hospital discharge, so in the immediate acute phase. End-stage heart failure patients, those with recent ACS, stroke, PCI, or CABG, as well as CKD with an eGFR of less than 30 were excluded in this study. And the average age of the trial population was around 70 years, and about 1/3 of them were women. As for in terms of when the drug was initiated, close to half of the patients had it initiated prior to hospital discharge, and a little over half of them within 3 days of discharge. So this study met its primary endpoint, which is the composite of total CV death, hospitalization for heart failure, and urgent heart failure visits, which was significantly reduced by around 33% with a hazard ratio of 0.67 and a p-value of 0.0009. So the absolute risk reduction was 25 with the number needed to treat of just 4. So this benefit was significant as early as 28 days after follow-up. And the trial endpoint had to be changed in the course of the trial. This was, of course, done blinded to the results because the trial had to be terminated prematurely due to COVID. So the original primary endpoint then was the first of CV death and hospitalization for heart failure, which was also met with statistical significance. And the effect of this drug was consistent across a number of pre-specified subgroups, including those with an LV ejection fraction less than or more than 50%, and the timing of the first dose, that is either before or immediately after hospital discharge. So they concluded that the benefits were across a range of EF, and also that initiation of SGLT2 inhibition in acute heart failure prior to discharge or shortly thereafter is a safe strategy.
This is, as we know, these drugs works in different ways besides being diuretics, and they regulate the glucose excretion as well. They came with this kind of phenomenal feature to prevent heart failure exacerbation, but having them started in the hospital, I think that was a unique trial compared to DAPA-HF that was presented maybe a couple of years ago.
Absolutely.
Do you see this drug kind of being prescribed before patient leaves, and what would be the barrier for this drug not to be prescribed for these patients?
So I think it might, just like every new drug, it might take time to sort of penetrate into practice. As for barriers, I live in South Asia. It might be a cost of availability of it coming down here. I don't know. It might be different for you in the United States. Also, perhaps cost. I'm actually not aware of what the cost of it might be, but
Right.
as with all game changer drugs, initially, I think we'll have those barriers.
Yeah. So this is again showed that, like this, still we have room for improvement. And usually patients with heart failure who are on this protocol are tightly controlled and have a very frequent follow-up. So even in cohort of patients who are compliant with their basic therapy, which is beta blocker and ACE inhibitor, still this drug showed benefit, which speaks to the
Great.
power of this new mechanism. Great, great study. Thank you
Absolutely.
so much. All right, so when I move on to the next one.
Yes, let me move on to SCORED, which looked at, once again, type 2 diabetic patients, this time with CKD and an EGFR of 25 to 60, as well as cardiovascular risk factors. So here, over 10,000 patients were randomized, and the average age was again around 69 years, but around 45% of the trial population here were women. The primary efficacy endpoint here was the same as the soloist trial, and this was met with a 26% reduction of total occurrence of CV death, hospitalization for heart failure, and urgent heart failure visits. Once again, the benefit of sotagliflozin occurred early, which was statistically significant at just about over 3 months. And the original co-primary endpoint, which was a composite of first occurrence of CV death, non-fatal MI, and non-fatal stroke, was also met, as was the other initial co-primary endpoint, which was first of CV death and hospitalization for heart failure. So a lot of ischemic cardiovascular endpoints being met there. In terms of adverse effect profile, diarrhea, mycotic infections, volume depletion, and decay were higher with sotagliflozin. And the benefit of the primary endpoint was consistent across a number of pre-specified subgroups, including those with or without heart failure, across the full range of EGFR and across both macro as well as microalbuminuria. Additionally, sotagliflozin was also seen to slow the decline in renal function after the initial 4 weeks. And furthermore, there was a significant reduction of the hemoglobin A1C across both moderate and severe EGFR categories with sotagliflozin. This is unlike pure SGLT2 inhibitors. But perhaps the most remarkable finding of this trial is that pooled data from both soloist and scored showed a highly significant reduction of the primary endpoint with consistent benefits in those with heart failure with reduced as well as preserved ejection fraction. So I guess there are lots of implications from these two trials. The benefits are seen across multiple subgroups: CKD, macro, microalbuminuria, heart failure with preserved ejection fraction. And very interestingly, the lower MI and stroke rates point towards an additional anti-ischemic effect of SGLT1. And the glycemic control has been achieved even in the lowest ranges of EGFR, which, as I mentioned, is also new and unlike SGLT2 inhibitors. And of course, soloist gives us an additional option, as we discussed, for the role of early initiation in the acute heart failure phase.
So in the second trial, there was some slow recruitment, or even the trial was stopped prematurely, as we talked offline. Do you want to just illustrate or describe to the audience what was the reason for that?
So I think COVID struck a lot of trial plans, not just this trial. And I think as a result of loss of funding, the trials had to be concluded prematurely. But what the trial investigators did was, in order to increase the number of event rates to maintain the statistical power of the trial, they included an additional endpoint into the composite, so that would increase the number of event rates, thereby retaining its statistical significance. This was, of course, done blinded to the trial results, and appropriate changes to the trial protocol had been made. But interestingly, I mean, despite the fact that the endpoint was changed, even the initial co-primary endpoints were met in the study. So the ischemic endpoints were met, and I think that's what's really exciting. It's beyond heart failure. It's also an effect on both MI and stroke reduction.
And as you mentioned, is a lot of trials got affected as well. And I'm wondering about the trial that's supposed to be initiated or currently ongoing with this COVID pandemic. What kind of when we're going to get these trials finished and how this is going to maybe slow in these trials to come up with a new therapy or new indication. Always, I mean, we have to find new ways to spread knowledge, also to have discussions and continue to have a collaboration that bring new ideas and new also didactic session to the audience to keep that education going and keep the knowledge going and shared with all healthcare providers. Well, with that, thank you so much, Aisha, for your time. Really appreciate you. I know you just came from work, and it means a lot to me to kind of have this few minutes with us. This insight on the trials was phenomenal. For our audience, we're going to continue to have this session on a weekly basis where we dive deep into the trials and new studies. So stay tuned with Heart Trending. Thank you, Dr. Qadir, for your time.
Thank you, Shadi. Pleasure.